Good evening, ladies and gentlemen. Welcome for today's live webinar on advances in multiple myeloma, an update from ASH. It's my honor and privilege to welcome Professor Dr. M.D. Agrawal. Sir is known to all of us. He's professor and head at Department of Hematology, Bombay Hospital, Mumbai, consultant hematologist at Leelavati Hospital, Bristol Hospital, Mumbai. Sir is president of Mumbai Hematology Group and has been the past president at ISH BT. Sir has been an institution in himself. He's been an inspiration for all of us. We as a country have been really fortunate, sir, to have you. It's because of you we have been able to hear from stalwarts in hematology on every weekend. Thank you so much, sir. And with this, I hand it over to you.
Thank you, Mr. Gopal, for your kind words. So good evening to one and all from India, and good morning, good afternoon to all of you from the rest of the world. Today, our guest speaker is Dr. Shaji Kumar from Mayo Clinic, Rochester, US. He's going to lecture on advances in multiple myeloma, an update from ASH December 2021. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Mice Ideas. I thank Dr. Manoj Kumar and the team INTAS, Mr. Rajesh Sharma and the team Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Shaji Kumar from Mayo Clinic, all our discussants who are themselves eminent hematologists or medical oncologists, and you participants for sparing your time. Tomorrow morning at 11:30 IST, we have the webinar on von Willebrand disease, diagnosis to be covered by Professor Jasmina Ahluwalia and treatment to be covered by myself. And this will be at 11:30 AM onwards. Our discussants today include very important personalities. We have Dr. Pravas Mishra from Max Hospital, New Delhi, Dr. Gaurav Dikshit from Action Cancer Hospital, Delhi, Dr. Satish Kumar from Manipal Hospital, Bangalore, Dr. Narendra Agrawal from Rajiv Gandhi, New Delhi, Dr. Mukul Agarwal from AIMS, New Delhi, Dr. Ranjit Sahu from AIMS, New Delhi, Dr. Pooja Prasad from Safdarjung Hospital, New Delhi, Dr. Deepesh Lad from PGI Chandigarh, Dr. Arihant Jain from PGI Chandigarh, Dr. Meet Kumar from Fortis, Gurugram, and Dr. Tejaswini Gudubande from Majumdar Shah Medical Center, Bangalore. And now it's my privilege to introduce Dr. Shaji Kumar, who needs absolutely no introduction to any Indian in the field of hematology and medical oncology. He has taught us everything about myeloma for the last 2 decades. He is consultant in the Division of Hematology and Mark and Judy Mullins Professor of Hematological Malignancies at Mayo Clinic, Rochester, Minnesota, US. He serves as the chair of myeloma, amyloidosis, dysproteinemia group, and vice chair for the research in the Department of Medicine, Mayo Clinic, US. He received his MD in internal medicine from AIMS, New Delhi. His postdoctoral training included residency in internal medicine, fellowship in hematology oncology at the Mayo Graduate School of Medicine, Rochester, US. His research focuses on development of novel drugs for the treatment of myeloma. His team evaluates in vitro activity of novel drugs that are likely to have activity in multiple myeloma. Promising drugs are then brought into the clinic through end-stage clinical trials, phase 1, phase 2 studies. His work is complemented by an active program studying the biology of myeloma, bone marrow microenvironment, and how it influences the tumor cells. His clinical research focuses on outcomes of patients with myeloma and amyloidosis, especially high-risk disease. He chairs the NCCN Myeloma Guidelines Panel. He's on the editorial advisory board of Leukemia, Blood Advances, Blood Cancer Journal, and Advances in Therapy. Also, he's associate editor for the American Journal of Hematology. So I invite him to give his lecture on advances in myeloma, an update from ASH, December 2002. Over to you, sir.
Thank you, Dr. Agrawal, and good evening, everyone else on the call today. Let me go ahead and share my screen. Does that look okay?
Yeah.
All right. So I'm going to talk about some of the advances, particularly with a focus on what had been presented at ASH last year, but more importantly, how do we put these new advances in the context of how we treat myeloma today and what can change for tomorrow? So, the myeloma treatment paradigm, and I'm sure you've seen the slides before, but I think it really drives home our approach to myeloma in general. And this figure is increasingly becoming more nuanced as the approaches have changed over time with the introduction of new therapies and better understanding of the disease natural history, particularly in the context of diagnosis and risk stratification. The diagnostic criteria, as you know, has evolved with the addition of some of those ultra high risk smoldering myeloma patients into the myeloma diagnostic bucket, so to speak, based on a very high risk of progression, more than 80% at 2 years. Now, despite that, we know at least another 30 to 40% of the smoldering myeloma patients are likely to progress to active myeloma in the first 5 to 10 years. And there is increasing interest in trying to intervene early for these patients. In order to intervene early in this precursor phase, two things need to happen. One, we need to be able to identify them more accurately. And second, we need to be able to identify who is going to develop myeloma soon so that we can target them for therapy. And then, of course, there are other questions in terms of what the appropriate therapy needs to be for those patients for intervention. Next, the area that has seen significant progress over the past decade has been the treatment of newly diagnosed myeloma and the continued use of autologous stem cell transplant and improved maintenance approaches. Now, despite these progress, the median PFS with the first-line therapy still is around 5 years with the current regimens, and patients do relapse, and we have to treat them multiple times over the course of the illness, eventually with these patients ending up with more relapse refractory disease. So there were some interesting presentations from the precursor phase, particularly from a early diagnosis standpoint. So as you all might know, the iStop study is a large screening study done in Iceland with the majority of the population over 50 getting screened. And these patients were then randomized to, obviously the patients with MUGUS were randomized to either no additional workup or they undergo the guideline-based workup. And then it's a third arm that actually gets followed up more intensively. What they were able to find, there were a couple of important findings. One, certainly we got a better sense of what the prevalence might be. And again, especially in the subgroup of patients who underwent additional evaluation, including bone marrow biopsy, the prevalence of smoldering myeloma was calculated to be about 0.53% in individuals 40 years or older. Now, clearly much higher than what we had assumed in the past. And that's primarily because we don't always do a bone marrow in every patient with MGOS and probably underdiagnosing some of the smoldering patients. Now, this study also showed that if you did more intense workup, not only do you upstage some of these MGOS patients to have smoldering myeloma, but you also identify a bunch of other diagnoses like amyloid, Waldenström, smoldering Waldenströms, etc. And if you do more intense evaluation as an arm 2, you identify more of them. And if you follow them very closely, then you're likely to identify many of them over the course of time, as shown here. But obviously, the key thing with all these studies is whether this early identification actually changed the natural history of the disease and allowed patients to live longer. And that is data that is absent at this point. And hopefully, with longer follow-up of the Icelandic cohort, we will get to know more about whether this kind of an early screening is appropriate for these precursor diseases. Now, the second part is, once you do make the identification of smoldering or diagnosis of smoldering multiple myeloma, we do want to identify the subgroup of patients who are at the highest risk of progression so that we can potentially leverage early intervention strategies. So one of the risk stratification approaches that was developed recently is the IMWG 20 to 20 criteria. Again, using a 20% plasma cells in the bone marrow, a 20 for free light chain ratio, and 2 grams of M spike. Now, most of these risk stratification systems are based on the values you get at the time of diagnosis, and it's unclear if that they still hold true years after diagnosis. So we looked at a cohort of patients looking at classify them at year 2, year 3, and year 5, and showed that the 20 to 20 model is true at any time after diagnosis, so that it is something that we can continue to use for risk stratification even years after diagnosis. And what we found was clearly some of those patients go from stage 1 to stage 2 or stage 2 to stage 3, but rarely did we find people who go downgrade over time. So clearly this is a tool that can be used for continuous monitoring as well. The next aspect of myeloma that we are increasingly understanding is the heterogeneity of the disease and the underlying drivers for this heterogeneity, primarily the genetic abnormalities. As you all know, the high-risk translocations, the 414, 14, 16, 14, 20, have been known for a while. We have data on 17p deletion that also is a strong adverse prognostic factor. 1q gain or amplification is something that could be found in as many as a third of the patients at diagnosis, with the frequency increasing with relapse. However, the prognostic value of 1q has been debated for a while. There's data presented at ASH from the endurance trial where we looked at the impact of 1q. And again, as with other studies that have reported about this before, about a third of the patients have 1q abnormalities, either 1q gain with 23% or 1q amplification in about 7% of these patients. Now, what we found was that irrespective of whether you treated them with VRD or KRD, the progression-free survival was inferior for the 1q abnormal patients. And what we found was that, again, with the endurance trial, we did not include patients with 17p deletion and other high-risk characteristics, but 414 was included. And in the multivariate analysis, what we were able to show was that 1q was an independent prognostic factor amongst this group of patients. And there was no difference in terms of PFS. But when you look at the overall survival, there seemed to be some advantage for using KRD in patients with gain 1q. And this is something obviously that needs to be studied prospectively. Now, switching gears and talking about newly diagnosed multiple myeloma, this is an area that has really seen some rapid changes in approach in the past few years. As you all know, the current standard of care for patients with the newly diagnosed myeloma is the combination of bortezomib, lenalidomide, dexamethasone, or the VRD regimen, which most of you use. The question is, can we make the VRD even better? And one of the approaches had been to add daratumumab to the RVD. The Griffin trial is a phase 2 randomized trial, randomized patients with newly diagnosed myeloma to getting VRD or daratumumab VRD. Then they underwent an autologous stem cell transplant and then received 2 cycles of consolidation with the same regimen, followed by 2-drug or 1-drug maintenance. So it's a single randomization, no subsequent ones, unlike some of the data from the Cassiopeia trial. So what was clear from the Griffin study is you can add daratumumab to VRD, leading to a deeper response rate. So we have almost 82% of the patients getting CR after 2 years of maintenance, and which is, again, another important aspect of the study. It is limited duration of years of maintenance. And in the absence of daratumumab, the CR rate is about 25% lesser. Now, we also, not only does the CR improve, but more importantly, as we all know, an important prognostic factor, which is MRD negativity, is also significantly higher in patients getting DARA VRD. In fact, 36% of those patients would meet the criteria for MRD negativity by the IMWG criteria, compared to only 15% for the RVD arm. Now, this improved depth of response have translated to a better progression-free survival, with the most recent update demonstrating that these patients gain almost close to being significant difference in the PFS. However, we still don't have data on any difference in the overall survival, and that should again, give us a little bit of a pause in terms of using a 4-drug combination in every patient with newly diagnosed myeloma. At least our own approach has been to use the 4-drug combination primarily in patients with high-risk disease, where we think getting to MRD negative is very important. Now, talking about MRD negativity, we saw similar data from the Cassiopeia trial. This is with the longer-term follow-up now. We can see that patients not only get to be or more likely to be in MRD negative status after consolidation, but they also are more likely to sustain the MRD negativity over long periods of time, both at 1 year and 2 years. And we know in addition to getting MRD negativity, the sustained MRD negativity is equal or more important in terms of improving the outcomes. And the Cassiopeia trial, there were a couple of important landmark analysis that was done, again, looking at 1 and 2 years after post-induction. And you can see that the people who are MRD negative in CR have better outcomes, particularly in terms of maintained or sustained MRD negativity. Obviously, this is important from the point of view of using the 4 drugs, but also how long you use it for. So, in the maintenance portion of the Cassiopeia trial, did randomize patients to getting DARA maintenance versus no maintenance. And the DARA VTD or VTD followed by DARA maintenance had the highest PFS rates. Particularly the MRD negativity was the highest in people who got 4 drugs followed by DARA maintenance. Now, there is still some unanswered questions with the Cassiopeia trial because people who did not get DARA during induction but got DARA during maintenance had the same benefit as people who got DARA for both phases, and also people who got DARA in induction without DARA maintenance, suggesting that, yes, use of the anti-CD38 antibody in the upfront therapy had significant impact, but it seemed to be similar whether you used it as induction, maintenance, or both, and whether the higher rate of MRD negativity in the DARA VTD followed by DARA maintenance will translate to better PFS for that particular group remains to be seen. Now, daratumumab is not the only anti-CD38. We have isatuximab that also works in a very similar fashion. And all the results that we have seen so far suggest that these 2 drugs are very comparable in efficacy. The German study randomized patients to isatuximab RVD versus RVD, underwent stem cell transplant, and then they were randomized to getting 2 drug maintenance versus 1 drug maintenance. Now, the second randomization is very important because the Cassiopeia trial obviously failed to give us definitive answers about the maintenance approach. The primary endpoint for the study was the MRD negativity at the end of induction. And remember, the induction was 6 cycles in this treatment, in this regimen. And clearly adding daratumumab had about a 50% improvement in the MRD negativity rate, or specifically bone marrow MRD negativity rate. Obviously, we need to see more longer-term follow-up to see if this would translate into better progression-free survival. But just as we saw with the Griffin study, the addition of isatuximab didn't really lead to a significant amount of toxicity. There was more lymphopenia that we often see in these patients. And obviously there's concern if we use all these therapies, if there would be increased risk of infections, but at least in the short term, there didn't seem to be significant differences. Excuse me. Now, the 4-drug combinations have not been just limited to carfilzomib or bortezomib for proteasome inhibitors. There was data from ixazomib. So this is the French trial which looked at ixazomib lendex with daratumumab combination as induction therapy, followed by autologous stem cell transplant, consolidation, and then maintenance with lenalidomide. So essentially very similar design to these other studies, with the exception that an oral proteasome inhibitor is being used here. And when you look at the response rates from the French trial, you can see that there's a deepening of response over time. And also over 50% of the patients were able to get to a complete response or better. Now, how does this compare to BRD data or KRD data? Very difficult to compare because of the differences in the patient population. But I think it still demonstrates the power of the 4-drug combination. And again, at least with a 2.5-year follow-up, we are not really seeing a significant, or we are seeing a good durability of response in these patients. Now, one of the questions that continues to come up with the 4-drug combinations is how long do we keep these patients on treatment? Obviously, the Griffin trial is looking at almost a 33-month treatment, including 2 years of maintenance and stopping therapy. But could we even stop earlier by using minimal residual disease testing as a tool? And the master trial it's a single-arm study that looked at DARA-KRD induction, single transplant, DARA-KRD consolidation, and after that, patients got additional consolidation or maintenance only if they continue to be MRD positive. So with this approach, they were able to show that the vast majority of the patients were able to get into a VGPR or better. And in fact, almost 50% of the patients were MRD negative with that approach. Now, is that a viable approach for stopping therapy? Well, I think it depends on the underlying risk. If you look at patients with no risk factors or one high-risk cytogenetic abnormality, they are able to maintain the response even when the treatment was discontinued at the MRD achievement. But in the high-risk patient population, even while on therapy, there seem to be patients who are relapsing, suggesting that the approaches to defining the duration of therapy cannot just be based on the depth of response, but also has to take into account the underlying cytogenetic abnormalities. There was another study from the HO1 group that again looked at ixazomib and daratumumab, so an IMiD-free regimen in an older patient population. They were able to show that the median PFS was about 17 months when ixazomib was added to daratumumab. Again, I think it's difficult to compare, and it's unclear what the role of this particular combination would be, other than the fact that potentially usable in the more frail patients. However, we know that the Maya study demonstrated that DARA-LEN can be used fairly easily in an old frail patient population with a median PFS that's almost 5 years, suggesting that that is the regimen that you want to continue to improve upon. And similarly, there was another trial of ixazomib and daratumumab from the French group that was presented with, again, results that are very similar to what we just saw with a median PFS of about between year and a half. And the overall survival, again, these are older patient population, but again, the study just shows that we can combine an oral proteasome inhibitor with daratumumab and getting benefit out of that. Now, kind of switching gears, obviously in the setting of relapsed multiple myeloma, we have seen a lot of changes, particularly the introduction of several new therapies, particularly immunotherapies. Now, we know that the CAR T cells, has made a significant or clearly demonstrate significant progress in the field. The Abecma or the ide-cel was the first CAR T cell to be approved earlier last year. And the data from the KarMMa trial using ide-cel clearly demonstrated the power of this platform with an overall response rate of 80 to 90% in patients with highly refractory disease. Now, the CARTITUDE-1 looked at a different CAR T. This is again targeted to BCMA. Some differences in terms of the T cell receptor having 2 binding sites instead of the 1 binding site with Abecma. But nevertheless, the overall approach is the same. Patients undergo apheresis for the T cells, get bridging therapy as needed, flu-cy lymphodepletion followed by the CAR T cell infusion. The cilta-cel demonstrated an overall response rate of about 98%. Nearly all patients responded with a median of 6 prior lines of therapy. And when you look at the with the longer follow-up, you can see that, again, responses are rapid and the responses appear to be quite durable as well. When you look at the overall patient population, the median PFS was roughly about 22 months. But when you look at the patients who actually got a nice response in terms of stringent CR, their PFS, median PFS was significantly better. And again, the 2-year overall survival for this patient population was about 74%, which is much better than what we would anticipate based on some of the natural history studies. Now, the other approach to immunotherapy has been bispecifics. Now, while CAR T is quite effective, there are significant barriers to using CAR T cell on a large scale basis, primarily because it's a complicated process, multi-step process, and very expensive. They can also be, especially in the later stages of the disease, doing the apheresis, then waiting for 4 weeks for the T cells to come back can be difficult for some of these patients with advanced disease. It may not be as much of a problem as we move it earlier in the lines of therapy, but nevertheless, if we are able to redirect the autologous T cells to the tumor without having to genetically modify that, that will clearly improve the ability to use it for more patients. So I think from that standpoint, the bispecifics are going to play a major role in the myeloma therapy in the next few years. The most likely candidate to be approved in the clinic earliest is teclistamab. This is a bispecific that targets CD3 and BCMA, or the B cell maturation antigen, allowing the tumor cells and T cells to come closer and leading to immunological cell death. When you look at the overall response rate with the initial studies of teclistamab, clearly not as high as the CAR T cells, but about 60% in a patient population that's quite similar to what went for the CAR T. And obviously, you also need to keep in mind, these are all patients, unlike CAR T, where you can see almost 20% of the patients dropping off between the apheresis and therapy because of disease progression. So I think it's difficult to compare the results from the bispecifics to the CAR Ts directly. Now, the bispecific antibodies appear to be very well tolerated. The major toxicity are hematologic, that particularly neutropenia, that could take sometimes a few weeks to recover. And then the next major toxicity is the cytokine release syndrome. The cytokine release syndrome can be seen in as many as 70% of these patients, but generally tends to be grade 1 and very few patients with grade 2 and easily manageable with the anti-IL-6, tocilizumab, or other approaches. One of the important findings from all these bispecific trials have been the increased risk of infection. Some of it's probably related to significant hypogammaglobulinemia that comes from this BCMA targeted therapy, getting rid of the normal plasma cells as well. But we also do see other infections, so something to keep in mind as we start using these therapies in the clinic. It's unclear how much of this is related to the drug versus the advanced stage of the disease these patients had. Another BCMA CD3 bispecific was the ABBV 383. Now, this is a little bit different from the teclistamab in that this is only IV, but it can be given once every 3 weeks. The way the bispecific is created, it is supposed to cause less CRS. In fact, when you look at the outcomes, you can see that patients, particularly the patients who got the higher dose of 40 milligrams or more, on the left-hand side, you can see that the cytokine release syndrome was seen in almost 70% of the patients, very similar to the teclistamab data, and the cytopenias in about a third of the patients. Neurotoxicity is extremely uncommon with bispecifics, unlike the CAR T cells, where you can see anywhere from 5 to 15% of patients with neurotoxicity or ICANS. When you look at the response rate, particularly focusing on the 26 patients who got the highest doses, you can see that the overall response rate is about 60 to 80%, with the increasing depth of response with longer follow-up. So it seems to be quite comparable in terms of efficacy compared to what we saw with teclistamab. Now, BCMA is not the only target that we are going after. There's also GPRC5D that is being targeted with the bispecific talquetamab, very similar in construct to the teclistamab, except for the antigen that it is targeting. Again, just like teclistamab, it can be given subcutaneously. And in the initial phase 1 study, what we have seen is again, similar profile of toxicity. Cytopenias can be seen in significant number of patients. Neutropenia can be seen in nearly half of the patients, especially at the higher dose levels. Now, in terms of the response rate, clearly it's an active bispecific. The response rates are in line with what we saw with the other bispecifics targeting BCMA. Now, with again, a group of patients that are highly refractory, almost 83% of these patients were vendor drug, and almost 2/3 of the patients are refractory to PI IMiDs and monoclonal antibodies. Responses are fairly rapid, and the durability appears to be quite promising at this time. And then there's a third target that the bispecifics have been developed against, and that is FcRH5. And cevostamab is a bispecific antibody targeting FcRH5 and anti-CD3. And in the phase 1 study, again, you can see very similar results. When you look at the adverse events, CRS can be seen in nearly 80% of the patients, mostly grade 1 or 2. And these patients clearly, and this toxicity can be easily managed as well. We do see that same signal as with the other bispecifics with the neutropenia and also the increased risk of infections. And obviously, as we get more familiar with the use of bispecifics, I'm sure some of these can be managed more effectively. In terms of response rate, especially at the higher dose level, you can see about 60% of the patients appear to have responded to treatment, including a significant number of patients who actually were able to get into an MRD negative state. So looking across all these different bispecifics targeting BCMA, GPRC5D, FcRH5, we are coming away with a response rate of about between 60 and 80%, CRS rate of about 70%, easily manageable, and hematological toxicity in about 40 to 50% of patients. So, so clearly, you know, the bispecifics, I think, are going to play a major role in myeloma therapy going forward, primarily because we are able to employ them right away instead of waiting for apheresis and the product to come back in 4 weeks. I think these bispecifics will be combined with other standard of care agents. We saw data at ASH with teclistamab being combined with daratumumab with excellent efficacy. So this will hopefully allow us to incorporate these bispecifics as part of the upfront treatment of multiple myeloma. Now, aside from immunotherapy, there are other drugs that also seem to have significant benefit for these patients. One of them is venetoclax. This is obviously been around for a while as treatment for CLL and mantle cell lymphoma. And here, the BELLINI trial randomized these patients with relapsed myeloma 1 to 3 prior lines of therapy to getting venetoclax, bortezomib dex, or bortezomib dex. The updated data clearly showed that the PFS can be almost doubled with the addition of venetoclax when you look at the overall patient population. As you may recollect, the initial data analysis of the BELLINI trial demonstrated an inferior overall survival for the venetoclax treated patients. And most of this was driven by early deaths related to infection in patients with high-risk disease. And as you can see with time, the curve seems to be coming closer. But the BELLINI trial also, I think, taught us an important lesson about the importance of precision medicine in myeloma. The phase 1 studies had clearly shown that on the phase 2 studies that the maximum benefit of venetoclax happens in patients with 11-14 translocation and those with a high BCL2 expression by gene expression signature. So we did some subgroup analysis amongst the BELLINI trial patients. And as you can see here, if you take the patients who had either 11-14 translocation or a high BCL2 expression, there's clearly benefit with PFS and no difference in the overall survival. If you take just 11-14 patients, significant PFS benefit, one of the highest hazard ratios we have seen for the relapse trials of 0.12. Even when you look at the BCL2 high patients, you still see a PFS benefit without a disadvantage for the overall survival. And one of the questions that always comes up is, since given the overlap, what about the patients who are not 11-14 but only BCL2 high, and those patients also appear to derive benefit? So clearly, the venetoclax-based approaches seems to be should be tailored towards patients who are either 11-14 or have a high expression of BCL2. We don't have a good assay for BCL2 in the clinic right now, so 11-14 is the only way we can select patients for using venetoclax. Now, the other exciting molecule, I think we saw the data at ASH, was iberdomide. Now, this we all know from the work over the past few years that IMiDs work by binding to the cereblon, which is a E3 ligase, leading to, again, ubiquitination of Ikaros, Aiolos, and leading to cell death. Now, the cell modes are a new class of drugs that are specifically designed to bind to cereblon, leading to activation of this downstream pathway and degradation of Ikaros and Aiolos, leading to myeloma cell death. Now, there was data that was presented from a couple of cohorts looking at iberdomide in relapsed patient population. One of the cohorts just looked at iberdomide dexamethasone in patients with at least 3 prior lines of therapy. And another cohort focused on using iberdomide dexamethasone in patients who had previously seen BCMA-targeted agents. And as you can see here, in both these groups of patients, the iberdomide was associated with an overall response rate of about 25%, including obviously patients who have previously become refractory to IMiDs. So we think this is going to be a valuable addition, particularly has the ability to replace maybe the current immunomodulatory drugs, both in newly diagnosed and relapsed settings. So where does that take us? Clearly, over the years, we have seen significant improvement in the survival of patients with myeloma. This is a recent data analysis looking at both the SEER data and the Mayo data. You can see in both these groups, the more recent patients diagnosed between 2014 and 2018 appear to have a continued improvement in overall survival. In fact, when you look at a subgroup of patients who are over 65 and has an ISS stage 1 disease and standard risk FISH, you can see at the right-hand side box, the green at the extreme right, you're almost reaching the standardized mortality rate, basically suggesting that you're achieving a functional cure for these older patients with standard risk disease with the current treatments. Now, the last few minutes, I just want to highlight an updated data from the Andromeda study. We saw the initial publication of Andromeda study that randomized patients to with newly diagnosed light chain amyloidosis to either receiving VCD, bortezomib cyclophosphamide dexamethasone, or DARA VCD. They received this for 6 cycles, and then patients continued on daratumumab for 24 cycles. This trial had shown an improved, what we call a improved depth of response, and also an MOD PFS, or major organ dysfunction PFS, which captured not only the PFS, but also persistent organ dysfunction. So in the primary analysis, we had seen that the VGPR rate was about 79% with the DARA VCD compared to 49% with VCD. Now with the updated follow-up, even though the overall VGPR rate has not changed, you can see that there has been deepening of response, particularly in the DARA VCD arm in terms of complete response. And we also see a deepening of the organ responses with the longer follow-up, almost twice as many patients in the DARA VCD arm getting a cardiac response as well as renal response. So I think there were a lot of data at ASH. I covered certain specific aspects, at least from the iStop-MM study, with lack of data suggesting that the natural history of the disease can be altered by screening. We do not need to routinely screen patients for MAGAs. However, patients at high risk, so patients over 50, with a strong family history or people with African American ancestry, those individuals are at a higher risk and certainly could be considered for screening. The 4-drug regimens clearly show deep responses and has to be considered for the high-risk newly diagnosed myeloma. Whether it can also be used for standard risk, I think we need to wait a little bit more to see what the survival data is. For the non-transplant eligible patients, I think the results with Dara-Lendex has been outstanding and certainly could be the treatment of choice if Dara is accessible. If in the absence of Dara, I think the BRD light regimen should remain the treatment of choice for these patients. For post-transplant maintenance, LEN is a standard of care. Whether adding something else to it provides a benefit remains to be seen. But in the high-risk patient population, based on the Forte trial, I think it's reasonable to consider dual drug maintenance for high-risk patients. Talking about high-risk patients, again, remains a challenge. A lot of ongoing studies specifically targeting this patient population. So hopefully it will continue to improve, maybe with the introduction of early immunotherapy. We have seen that the data shows durable responses with the immunotherapies, even in the late stage disease. And whether it is going to be true or even better in the early stage remains to be seen at this point. And so clearly a lot of advances in the treatment of myeloma. And I will stop there and thank you for your attention.
Thank you so much, Dr. Shaji, for that beautiful update. Enjoyed listening to you. There's some of our colleagues here who I request them to open their videos and use raise hand sign for asking questions. Meanwhile, we'll start some questions with the audience. Dr. Roshni wants to know, should 1Q gain be done for all newly diagnosed and relapsed myeloma? And does addition of DARA to triplet in gain 1Q myeloma improves the prognosis?
Yeah, it's a good question. I think with the data that we have right now, I think it's fair to say that we should look for 1Q abnormalities, not only at the time of diagnosis, but also the time of relapse, because patients can definitely occur this over time. Now, whether DARA has a specific effect on 1Q is unclear, but I think more intense regimens will allow us to get deeper responses in these patients, which clearly I think is going to be important for the long-term outcomes.
Thank you. Mukul, your question.
Thank you, Dr. Shaji, for an excellent overview. My question is about bispecifics. So you particularly pointed about the infection-related complication with bispecific. So what kind of infection do you see? Are they bacterial, fungal, more of atypical, viral? What kind of prophylaxis do you use? And do you use IVIG as a prophylaxis in them on a monthly basis?
Yeah, all good questions. And remember, all the bispecific experience has been in the context of clinical trials. The majority of the infections are bacterial. Pneumonia seems to be the most common. In terms of antibiotic prophylaxis, most of the trials have not employed routine antibiotic prophylaxis. I think that's something we need to get a better sense of in the real world setting, partly because we don't know how much of this is because we are watching these patients so closely and how advanced these patients are with all the therapies they have had before. But in terms of unusual infections, again, we do see some viral infections, but predominantly it tends to be bacterial and very little in terms of fungal infections. In terms of IVIG, these patients can be profoundly hypogammaglobulinemic, but our approach has been to use the IVIG only in the setting where patients are developing infections. If someone has not had any infection, we probably wouldn't preemptively treat them with IVIG. So that has been the approach, and that might change depending on as we have experience. It's quite possible that we might treat them with IVIG at least for the first few, maybe less often, every 2-3 months, but for the first year or so of therapy.
What changes like this would you expect when you come from clinical trial to the routine OPD or office practice with these bikes?
Yeah, I think the key thing is going to be obviously the cytokine release syndrome is fairly common, right? So these patients have been chosen very carefully in terms of their ability to withstand their CRS. So I think there's going to be a steep learning curve as we take patients with comorbidities, especially cardiac issues or coexisting amyloid, to using these bispecifics, and we might end up with more CRS. That's a possibility. The infections, there's a potential for it to be more if you are going to be taking very sick patients to these treatments. And I think generally what we see with all these therapies is there's going to be a wave as soon as the drug is approved of really sick patients going on treatment. And you're going to learn a lot more about potential toxicities. And then you learn how to use the drug, and you also start using in patients who are more fit. So there's always going to be that initial increase in perceived toxicities.
Thank you, Mukul. One more question from the audience. Dr. Bhausahib wants to know, part 2 of Cassiopeia had no maintenance in the control arm. How does this impact the conclusion drawn about the benefit of DARA in maintenance?
Yeah, so the Cassiopeia trial, I mean, it's an important trial, no question about it, but the data, I think, is not very applicable in today's practice. One, it was designed at a time when RUF maintenance, lenalidomide maintenance was not standard. So it's really difficult to extrapolate the true value of DARA maintenance. I think in patients who have not seen DARA in the upfront setting, it clearly is the maintenance. And remember, this was given once every 8 weeks, gave almost the same benefit as people who got the DARA in the injection therapy. So I think it certainly limits how much we can extrapolate from the Cassiopeia for our day-to-day maintenance. Again, thalidomide not being used that often anymore.
Thank you. Dr. Arihant?
Yeah. So good evening to all. Am I audible?
Yes.
Yes.
So my question is regarding the use of venetoclax upfront versus at relapse in 11-14 translocated patients in myeloma as well as the amyloid setting.
Yeah, so there's no data on the upfront setting with venetoclax. We and others are in the process of doing some trials looking at venetoclax combinations in the newly diagnosed setting to see if adding such a drug in the 11-14 early on can allow us to get deep responses. In the relapse setting, clearly the 11-14 patients benefit just with Vendex or Vendex in combination with other drugs. The amyloid setting, it certainly has been very active. I remember that unlike myeloma, where 15% of patients are 11-14, almost 50% of the patients with amyloid are 11-14. So clearly it benefits a lot more patients in that setting. And again, we only have retrospective data and some ongoing phase 2 trials looking at venetoclax in amyloid, but I'm pretty certain based on our experience that are going to be positive trials.
So one more question. So this is regarding picking up extramedullary disease at baseline, like how aggressive should be in terms of doing PET scans, and on follow-ups who have achieved a biochemical, say, stringent CR or better. So, and even say marrow MRD negativity. So how frequently and should you be monitoring them? And if they have a isolated or some extramedullary disease, but they are in MRD negative remission in the marrow, so what's your approach on those patients?
Yeah, important question. I think if it's ideally, I think we should do a PET CT in all these patients at diagnosis. Obviously, it becomes a problem with limited resources, but I think we should try to do that. If we do that, we're going to identify extramedullary disease in about 7 to 9% of these patients. That would not have been detected otherwise. Will it change management? It could change the way we monitor these patients, and also clearly identifies a group of patients with high-risk disease. So I think it's important knowledge we have at baseline. The second time point where I think it can be really useful is when patients are in a deep response after your planned initial therapy. So we tend to do a PET CT in a significant number of patients, kind of 3 months out from their auto transplant. And we have shown that in the setting of, and the French group have shown too, in the setting of bone marrow or IMWG MRD negativity, if you also have a negative PET CT, your outcomes are better. And recently we published on our day 100 post-transplant experience, again showing that presence of PET abnormality, even in the phase of MRD negativity, is associated with poorer outcome. So if you find somebody with PET positive lesions, I think it may be a signal that either you want to give them additional consolidation or you want to monitor them closely for early relapse.
Thank you, Arihant. One more question from the audience. Dr. Kalantri, maintenance strategy for high-risk myeloma, post-transplant dual maintenance duration, and MRD-guided maintenance to choose between single versus dual.
Yeah, so the data for use of a dual maintenance in the high-risk setting, I think it's pretty solid. If you look at the Forte trial, the subgroup of, if you look at the hazard ratio, which is the incremental benefit with 2 versus 1, is almost similar in the high risk and in the standard risk patients. The other set of data is from when you compare across the endurance trial, right? So those are standard risk patients getting VRD or KRD induction followed by LEN maintenance. PFS was 36 months, right? Or almost 36 months. If you look at the SWOG study for the high-risk patients using ELO VRD versus VRD followed by VR maintenance in a high-risk patient population, the PFS is again close to 36 months, suggesting that the high-risk patient population, by giving them a dual drug maintenance, your PFS, you're able to bring them almost to the same level as the standard risk patients. So I think in our practice, we routinely use the PI and IMiD maintenance for high-risk patients. Now, is the PI critical, or is it just the fact that you're giving 2 drugs versus 1 drug? What is playing a role? We don't really know, but we will get more data as we have the DARA LEN maintenance studies read out. In terms of MRD-guided discontinuation, we know MRD is a strong prognostic factor. It's really nice to be able to be MRD negative. What we don't know is at the end of the planned therapy, if you're MRD positive and you give them extra treatment to make them MRD negative, will that change outcomes? We just don't know. Similarly, we don't know if we discontinue or de-escalate therapy in somebody who is MRD negative. Is that a right approach? I think the master trial took a stab at it. It is not definitive data in terms of whether we can implement it yet, but I think it's quite intriguing. And I think, again, the SWOG study that's looking at the DARA-LEN versus LEN maintenance post-transplant has a randomization that's based on MRD negativity, and that will tell us whether it's an actionable tool in the clinic.
Thank you. Dr. Satish.
Thank you, sir. Thank you, Dr. Shaji, for that comprehensive and concise talk. I had a couple of questions regarding maintenance only, partly answered in the last question. So one of the trials showed that after induction, especially in high risk, you suggested that we can translate that after induction, we can give DARA maintenance and avoid DARA in induction. So that is very helpful in our population where DARA induction is going to be very expensive. So in high-risk patients, after induction, say with VRD in transplant, non-eligible after maybe 9 to 12 cycles, giving daratumumab should make the same impact on MRD as giving DARA in induction. Am I right in interpreting this, sir?
So let me just clarify that point, right? So one is the Cassiopeia study was not just high risk, it's all patients, right? So, and in those, so what we found is at this point in time, the PFS appears to be similar, whether you got 4 drug followed by no maintenance, 3 drug followed by daratumumab maintenance, or 4 drug followed by daratumumab maintenance. All 3 appear to have the same PFS. However, the MRD negativity was the highest for people who got DARA VGD followed by DARA maintenance. We have not seen that reflect in the PFS difference yet, but it's quite possible 5 years from now that we might start seeing a difference between the curves. That's why I said it's not a definitive data we can necessarily use to decide to do DARA maintenance only or induction only or both. But it just raises a question that it's, that this is a question that is not answered yet. High-risk patients, I think the maintenance, until we have more longer-term data with DARA maintenance or DARA-LEN maintenance, personally, I would use either bortezomib-len or carfilzomib-len for maintenance in the high-risk patients.
And this maintenance will be indefinite, sir, until progression?
Maintenance until progression is what we've been using for the high-risk patients.
Thank you.
Thank you, Satish. One more question from audience. Dr. Shyam wants to know, 72-year-old lady, myeloma, pleural effusion confirmed to be due to myeloma, treated with bortezomib pom-dex 4 cycle. Marrow has gone in remission, but pleural effusion keeps recurring. How do you manage this patient, and whether there is a role of intrapleural bortezomib?
That's a good question. I think, again, unusual presentation, but clearly a high-risk characteristic. Since we use bortezomib pom-dex, I just want to clarify, I don't know if you're able to clarify, it's newly diagnosed or is it a relapsed patient?
I mean, this is all what is mentioned.
Okay. I'm just thinking it may be relapsed because of the POM, but there's really no proven role for intrapleural administration of any of these therapeutics. I think these patients, especially if they're responding to therapy, and sometimes the effusion can become more chylous. It's just more of the lymphatic obstruction phenomenon rather than really exudative or directly tumor related. In those settings, of course, you can look at pleural disease in concert with effective systemic therapy. But clearly, I don't think there is any proven role for intrapleural administration of these drugs.
Thank you. Dr. Ranjit?
Good evening, sir. So it was an excellent talk, sir. I have got a couple of questions in myeloma. Now, what is the impact of extramedullary disease when you are using 4 drug regimens? And to extend that question a bit more, how do you treat these multiple plasmacytomas with minimal bone marrow involvement?
Yeah, for sure. So obviously 2 different categories of patients, one a bad high risk and one is actually a good risk group. The extramedullary disease patients, again, we don't have a lot of data with the 4 drug combinations because those subgroups haven't necessarily been teased out of the Griffin or the Cassiopeia study. But generally, the extramedullary disease do tend to respond well to the PI-IMiD monoclonal antibody combinations, at least based on what we have seen in the relapse setting. So I think the key with the extramedullary disease is to try and use multi-drug combinations because these cells often tend to be, there have been studies showing that, for example, the myeloma cells in the extramedullary disease in the relapse setting is more likely to carry a 17p deleted clone. So when you see that, you always think, again, these are not extramedullary disease that it's an extension of a bone lesion. These are truly soft tissue extramedullary disease. And those patients, I think, trying to use the multi-drug combination is probably the best way to go. The multiple plasmacytomas with the minimal marrow involvement is a very interesting subset of patients. They generally tend to be, not very often do we see them, but they generally tend to be very responsive to transplant-based therapies. So those patients actually do very well with the standard induction transplant and maintenance.
Can I ask one more question, sir? Yeah. So interestingly, in one of your slides, you have shown that the transplant with high-dose melphalan you are doing at day -2. Now, is that become a standard now these days to do it on day -2?
So yeah, we generally have been doing a day off between the melphalan and the stem cell infusion. It's interesting. We looked at, several years ago, we changed our practice to give a split dose or a single dose and no break in between. And we did see a slight difference in terms of delay in engraftment when you give the stem cells right away after the day after the infusion. So we kind of went back to using a break before we actually infuse.
Does it matter whether the patient has some renal failure and those patients who do not have renal failure, because the clearance is halted?
Yeah, for the renal failure, we often use dose adjustment, right? So we generally tend to use 140 milligrams. Sometimes we do give them split dose over 2 days as well. But the dose reduction, I think, is important for the renal failure patients.
My third question in myeloma is, in a 3-drug regimen, which we commonly use in India because of socioeconomic reasons. How do you choose between your PI and IMED? Which one do you prefer and in what settings in upfront?
In the upfront setting, you mean using either PI or IMID in a doublet, or is it a triplet?
Triplet regimen.
Okay. So which PI and which IMID is the question then, right?
Yes, sir.
Yeah, I think most of the data that we have is with VRD, and I think that still remains our choice, especially now that bortezomib is becoming generic, Len is becoming generic. So I think that VRD triplet clearly is highly effective and certainly going to be less expensive than many other therapies too. In patients with pre-existing neuropathy, I think there's clearly an argument to using carfilzomib instead of bortezomib. Based on the subgroup analysis from the endurance, one can make an argument for using KRD in patients with a high-risk cytogenetic abnormality compared to, or a 1Q abnormality compared to V. But I think that's again retrospective data. I think the difference in approach for a high risk is not just switching from V to K, but more adding the fourth drug.
Thank you, sir. Thank you very much.
Thank you, Ranjit. Another question from audience. Dr. Panda wants to know, is DTP renal scan mandatory before autologous stem cell transplant, or creatinine clearance is good enough? And another part is, if creatinine is normal, but the estimated GFR by DTPA is 48 ml per minute, what will be the dose of melphalan?
Yeah, so we don't typically do a DTP scan. I think we just go with the creatinine clearance. And we usually, again, the dose modification is probably a combination of an age and renal function. So if somebody with a 48 ml per minute, I would not change the dose of melphalan. But I think if you get down to closer to the 30 to 40 or below, I think a dose modification to 140 is reasonable, particularly in the older patients. In the younger patients, we often have a higher threshold. I mean, we generally tend to stay at the 200 for as much as we can.
Thank you. Dr. Gaurav?
Thank you, Agarwal sir. Thank you, Dr. Shaji, for a wonderful talk. Although some of my questions are already answered, but I have a doubt about MGRS. Not many studies are available with this entity, and I have how to go about it after induction, and should we go with maintenance, or what is the role of bisphosphonates in this entity? So can you share something about it?
For sure, yeah. So I think the MGRS, again, we are talking about the monoclonal gammopathy with with some kind of renal injury, right? Most of the times these clones are really small and they're really truly a Merck's clone. And obviously they don't have any bone disease, otherwise they would be myeloma. So I would not necessarily use bisphosphonates in those patients unless they have osteoporosis that's beyond what you would see for their age, or if they are older, clearly has osteoporosis, then you can follow those guidelines. In terms of the type of therapy, again, we are trying to control this clone. And unlike the myeloma clone, the risk of this clone coming back is fairly low. So generally, our approach has been to use the similar induction therapy and then closely follow the clone or the M protein or light chain. And if we can get a really good response, we may not always even offer a stem cell transplant to those patients. We would just give a limited duration of therapy to maximal response, and often just discontinue therapy and watch. Because most of the time, the renal abnormality, especially if you get to a complete response, the renal abnormality is going to improve and won't worsen without the clone coming back. Can be challenging if in several scenarios, right? So the easiest is you give them 6 to 8 cycles of therapy and they go into CR, and that's the best scenario. The question is, what happens when you have somebody who is not in a CR, but the kidney function is improved? I think it's reasonable to watch those people because you probably have gotten the numbers below where it matters. The third group is people who have not gotten a CR and the renal function has not improved. And there we really have to try and add on more therapy. And those are the patients whom we may consider consolidating with the transplant, trying to get a deeper response, hoping that that would translate to an improved renal function. The worst is obviously the people who have the clone disappears and the kidney function continues to worsen, and then you're really stuck. You don't know what to do with those patients. And it's certainly important to go back and look and see if there are alternate reasons why their renal functions worsening.
Any role of maintenance?
I would not maintain them unless, again, you have a persistent clone beyond the primary therapy. Or in people who have a significant clone, obviously they kind of fall into a gray zone in between. If you have somebody with significant plasmacytosis, doesn't meet the criteria for myeloma, but he has a different renal lesion that is explaining the renal insufficiency. Those patients, one could argue that maybe a maintenance approach like myeloma is important to maintain the clone down.
Thank you.
Thank you, Gaurav. Another question from audience. This is again about pomalidomide. Dr. Shah wants to know if it's easily available. Would you consider this upfront in place of LEN? There is a little study published from TMC Kolkata on this front, about 50 patients.
Yeah, so it's an important question, but there's very little data, right? So all the phase 3 trials have been using lenalidomide. So I personally would not switch them until I have data to show that using the POM has an advantage over LEN. Remember that POM tends to have more hematological toxicity, so we have to be very careful about using that upfront, particularly in patients whom we are thinking of taking to stem cell transplant. So at this point in time, I think I still reserve POM for second line and beyond.
Thank you. Dr. Tejaswini.
Good evening, sir. With the use of these monoclonal antibodies, we are, especially daratumumab, we are seeing a lot of CNS disease, that is CNS disease at relapse. So what would be the best treatment for CNS disease?
Yeah, so I'm not sure if daratumumab has any direct effect on the CNS disease. I think it's partly because patients are living longer with these newer therapies, and we are seeing that more. In terms of treating the CNS disease, it's challenging. Many of the drugs can cross the blood-brain barrier, including pomalidomide, the proteasome inhibitors. So certainly, our approach has been to use intrathecal therapy to try and clear the CSF, and then use multi-drug combinations to try and control the disease systemically. It's mostly palliative. This disease invariably would come back in a short order.
Thank you, Dr. Tejaswini. Dr. Satish.
Thank you, sir. Sir, I wanted to know your approach for biochemical relapse when it happens in high risk, standard risk, and on maintenance, early versus late.
Yeah, so I think biochemical progression, I think it's an unanswered question whether we should treat patients at biochemical progression or clinical progression. In fact, we are starting a phase 3 trial in ECOG that's asking that question of, should we start randomizing patients to get started on treatment at MRD becoming positive versus actually getting a M spike of 0.5. So currently with what we know, at least our approach has been that patients with high-risk disease and patients with an early relapse, right, which basically means high-risk disease, biochemical progression should be the trigger for starting therapy. For standard risk disease, I think we can watch them a little bit closer for a longer period of time, as long as we can do serial imaging to make sure there is no extramedullary disease or bone disease that's worsening, despite not having a lot of change in the M spike. So those patients, I think with careful follow-up, we can probably delay therapy for some more time. Now, we also have to take into account, how advanced or, how late the relapses are, because once patients get to like the third, fourth, fifth line of therapy, they tend to make less and less of the M spike. And so we have to be more and more careful about waiting for other characteristics.
Right. Thank you, sir.
Thank you, Satish. Dr. Bhausaheb also wants to know about that in Bellini trial, there was a better tolerance to venetoclax in patients who had T1114 or BCL2 high. Why? And is there a subgroup of patients where venetoclax should be avoided?
That's an excellent question. So in terms of tolerance in terms of the typical side effects that we see, like the cytopenias and the GI toxicity, there was no difference based on the 11-14 translocation. But the difference that we did see was the infection rate. And the subgroup of patients who seemed to have early progression and infection-related death were the people who did not have 11-14 translocation, did not express high levels of BCL2, and more likely in the group that also had high-risk abnormalities like a 4-14 translocation or 17 deletion. So I think right now, I would not use venetoclax outside of 11-14 at all until we have an assay that tells us who are the true BCL2 high patients. Once we have such a validated assay, I think we can expand the treatment to those patients as well, and which would cover about 40 to 50% of patients. Remaining patients, I would not use that drug.
Thank you. Arihant?
So, two questions. One is regarding managing myeloma with renal impairment, where the renal impairment tends to persist maybe beyond 2 cycles or 3 cycles. How do you decide whether you use a reduced dosed lenalidomide or you tend to prefer the safer cyclophosphamide, say if you are using a standard RVD versus VCD triplet? That is the first one. And the second one is regarding extramedullary relapse. How frequently are they cytogenetically discordant from the medullary disease, and should we be doing the FISH, etc., on the solid tissues as well, and does it impact your judgment?
Yeah, so for the renal insufficiency, I think increasingly we are starting to use daratumumab bortezomib combinations as the initial therapy, because obviously no change needed for renal function. And once the renal function improves, we would introduce the IMiD in this patient population. Now, whether we continue with the 4 drug or we drop the V or the D all depends on whether we are going to take them to a transplant, whether they have underlying high-risk cytogenetics, and the tolerability. But typically the approach would be DVD, add R when possible. Now for the extramedullary disease, there are studies showing that the clone that we see in the EMD is probably more evolved than the one we see in the bone marrow. So if you do FISH, we will find differences, but the question is whether that will change your therapy. And at this point in time, it would not change the therapy. The very fact that you have extramedullary disease already indicates high-risk disease.
Sorry for the first question again. So say if DARA is not an option, what is your say?
Then I think VCD would be reasonable to use. With the caveat though, there was a French study that showed no benefit to adding cyclophosphamide to bortezomib with the renal failure setting. So I think it remains up in the air whether cyclophosphamide really adds much, or we are kind of dependent completely on the bortezomib and dex. I mean, one can always consider adding thalidomide to it. That's an option because it doesn't affect the renal clearance. Or else you can just go ahead with the len at a small dose. Start off with the 5 and then titrate based on tolerability.
Thank you.
Thank you, Arihant. Dr. Mukul?
Sir, first is a very basic question. Since there's so much talk about extramedullary disease, so which is your imaging modality for choice for newly diagnosed myeloma, clinical myeloma proven PET scan, or a whole body low-dose CT, or an MRI, whole body?
So generally we tend to do as I said, a minimum would be a whole body low-dose CT scan. The preference would be to use a PET CT. PET CT would be the preferred imaging modality. MRI is generally limited to the setting where you have somebody whom you think has a high-risk smoldering, or you have a smoldering myeloma, and you want to distinguish from active disease and the PET CT is normal. A spine MRI can sometimes be helpful making that distinction. Or patients present with any CNS neurological symptoms, I think a MRI of the spine would be called for. Otherwise, we are relying primarily on PET CT or whole body low-dose CT.
And second is about MRD in myeloma. So MRD negativity is a good tool for studying drug efficacy in clinical trial. That is fine. And MRD negativity shows a good prognosis. What to do with MRD positive cases? Do we treat them further? How frequently do they relapse? Because there was a question on biochemical relapse treatment as well.
Well, I mean, eventually all patients relapse, right? It's a question of
Yes.
time to relapse. And I think the MRD positive, they are going to have a shorter time to relapse, especially if they have underlying high-risk cytogenetics. So to your point, I don't think I would, in the average, standard risk patients, I would not change therapy based on the MRD status, particularly either escalating or de-escalating. The high-risk patients, so if you have somebody who just coming off their auto transplant, MRD positive, has underlying high-risk disease, I would seriously think about doing additional consolidation, either with a tandem or additional cycles of therapy before going to maintenance.
In your current practice with so many trials and everything, are you still considering patients for allotransplant?
Very, very uncommonly. I think there is very little to suggest an upfront allotransplant at this point with all the therapies we have. So generally, even though we have these multiple high-risk markers, sometimes patients with high-risk disease can get really durable benefit from the current approaches. So if I have a patient who gets, let's say, auto transplant and then maintenance, and they relapse within 18 months, I would certainly consider taking or at least offer them an allotransplant, especially if it is a patient who has high-risk underlying abnormalities.
And not for a CAR-T kind of therapy.
It's a discussion to be had because CAR-T, again, we don't have any data and we can't use them because CAR-T is only indicated for 4 lines of therapy and beyond. So we certainly cannot take such a patient to CAR-T at this point. Yes, we can keep putting them on other therapies until they get to 4 lines and then use CAR-T, or wait, the future CAR-T may be available early on. But if you have a 40-year-old, let's say, coming to you with a 414 and a 17p deletion, and you give them the standard, four-drug combination transplant maintenance, and they relapse in 2 years, I think the writing is pretty clear on the wall that it's unlikely to be controlled for the next 20 years. So I think those patients, I think I would have a serious discussions about an allotransplant.
Thank you. Meet.
Thank you so much, sir. Sir, first of all, a comment. We have seen now 2 patients post-DARA at different time points to have CMV colitis. So how commonly have you seen this? Like, I'm not very sure. Definitely data is there to support that DARA is showing an increasing incidence of CMV colitis post-DARA at different time points. That is one. And second thing, is there any patient category for whom you do not recommend transplant in your clinical practice as of today?
Good question. So the DARA, we know it can cause viral reactivations. Clearly, the hepatitis B has been reported and it's part of the package insert. I have not seen any CMV reactivation at this point, or CMV disease with DARA in any of the patients whom we have treated. So, it's I think it's possible because of the fact that it does suppress the immune system and you can see other viruses being activated. So certainly something to keep in mind, especially when these patients present with unexplained cytopenias and other symptoms. The second question, in terms of patients whom you would not consider transplanting, I mean, if the patient can, sorry, go ahead.
The transplant patients for whom you would not offer.
So transplant eligible patients whom we would not offer. So really not. I mean, I think it all depends on the patient preference. If it's a transplant eligible patient population and they want to delay the transplant to the first relapse, I'm completely fine with that, unless they have high-risk disease, in which case I would try to push them towards transplant, because that definitely will give you a deeper response compared to no transplant. So I think a lot of that is kind of driven by the patient preference, at least in our own practice. But there are no definitive contraindication or something. There's no reason I can think of where I would not take a transplant eligible patient to transplant.
Okay, sir. Thank you, Meet. Dr. Tejaswini.
Sir, if we were to predict the progression of monoclonal gammopathy to multiple myeloma or smoldering myeloma to which is the latest, like which marker Like not the scoring system, but the marker, which one would be the best? Like what is the latest in the research field?
So I think from the clinical application wise, I think we are still dependent on the M-spike free light chains, the FISH data. I think those three can be used, and the bone marrow plasma cell percentage can be used both for muggers and for smoldering. Now, in terms of things that are still in the research realm, clearly there are gene expression profiles that can predict for a higher risk of progression, presence of circulating plasma cells, immunoparesis, and also some of the mutation profiles have been suggested to again identify people at a higher risk of progression. But none of these are, can be used in the clinic right now.
Thank you, Dr. Tejaswini. Any other question? I have no question from the audience left over here. Yeah, Arihant.
So this is regarding more of the epidemiology part. So in the Indian context, like we still see a lot of newly diagnosed myeloma patients coming in really advanced stages of organ failure, paraparesis, lot of extramedullary disease at presentation. So we discussed the Icelandic study, but so in the Indian context, do you still feel there may be some population groups where you would want to offer, say, a screening program sort of a thing, say, the ones presenting with low backache, or so? So maybe something to which we can even look at or in our population. What's your guide on that?
I think it's going to be, it's the screening is, it could be a very dangerous tool if not used appropriately. And I think especially in a resource constrained setting, I would actually be even less enthusiastic about using screening, because you are going to identify a lot of patients with muggers. That's going to take a valuable healthcare resource and further away from the patients who really need it. So I certainly would not consider that. I think education is going to be the important thing, educating the primary providers.
Thank you, Arihant. I think that's the last question. Dr. Shaji Kumar, thank you very much. Very elaborate question answer session. Though we have had so many sessions on myeloma, the curiosity of various odd questions, difficult situations persists. It's amazing how the things have been developing. And I'm grateful to you for sparing your early morning on Saturday once again to educate us. Today we have participation from almost 23 countries. And I think all of them will benefit a great deal in taking care of their myeloma patients. Also grateful to all the audience over here. For the official vote of thanks, we have Gopal from Indus.
So
thank you, and great seeing everyone.
Thank you, sir, for giving us this opportunity for participating. I would also like to thank Dr. Shaji Kumar for an excellent talk and helping us to clarify all the doubts regarding multiple myeloma. I would also like to thank all the discussants for today, especially Dr. Gaurav Dixit, Dr. Satish Kumar, Dr. Arihant Jain, Dr. Ranjit Kumar Sahu, Dr. Gaurav Dixit, and Dr. Tejaswini and Dr. Mukul Agrawal for sparing time from the busy schedule. As stated by sir, we have had participation from, in fact, sir, 29 countries, what I get an update. And just to name a few, it's across, sir, means you look at Algeria, Italy, Mauritius, Singapore, Qatar, Thailand. So thanks to all the participants. It would have not been a success if we don't get participation from clinicians across the country. So thank you so much. It has been really a good webinar. Wish you a good weekend ahead and good night to each one of you.
It speaks volumes about popularity of Dr. Shaji Kumar. So many countries. Fantastic. Thank you.
Thank you.
Thank you.
Thanks everyone. Take care.